from your perspective, in terms of patients that you are recommending this treatment to, are there certain categories of patients that you feel like it's more appropriate for? Do you tend to discriminate or select certain types of groups of people or characteristics of the lesions? Tell us more about your thought process in recommending this treatment for people.
Yeah, so I think the easiest patient to recommend treatment for is the patient who's already lost central vision from either a disciform score or from GA in their fellow eye. So the conversation, with any, honestly, with any size or any type of GA, we're talking about, extrafoveal or subfoveal. I usually will have a pretty simple, straightforward conversation with them about it, and they're quite eager to actually get started on treatment and just maintain what they have for as long as possible. Other situations where people come in, a lot of the times it's just people coming in who say, "Well, I can tell that my vision's been declining over the last couple of years, and is there anything I can do about this?" And if they do have GA of any sort and they are complaining of reduction, and I can see that it's likely from the GA, we're having the conversation. I'm offering them treatment. Now, if I am offering them either one of these agents now, I never am doing bilateral treatments on the same day for the first time. I'm usually treating the worst eye one time on its own and seeing if there's any response in terms of inflammation or any problems with it. Once that's done, then I will proceed to treat both eyes if they need it in both eyes, if they do have GA in both eyes. It's a nuanced conversation. I think in a lot of instances, patients are referred in and they say, well, the doctor says there's an issue here. I'm not really sure if there is one or not, particularly these extrafoveal lesions. And that's a more complicated discussion because they are the patients that are going to actually have their lesions grow faster. We know that extrafoveal ones grow faster than subfoveal in most cases. So, they are probably at more risk for progression in those coming years. But at the same time, if they're not symptomatic, it may be a little bit more of a difficult discussion to have. And so that's where you kind of have to turn into a bit of a glaucoma specialist in some cases in terms of how they show visual field data and things like that, or show optic nerve photos or show progression to kind of convince the patient that they need to be compliant with therapy. In our case, I think using autofluorescence is actually a really nice way, kind of showing if you do have longitudinal data from, say, a few years ago and showing the lesion size from the autofluorescence then until now, can be very helpful to kind of convince a patient that it may be better for them to start treatment, given the fact that these lesions are growing at a relatively fast rate. I think there's a lot of nuance to all these discussions, and a lot of times I will offer the therapy and then give them information about it, and then tell them to come back in a few months and then just kind of review it with their family members and see if it's right for them.
I can certainly see the value of showing someone their images over time and seeing how that helps convince someone for the therapy. In terms of, once you already have them on the therapy, so let's say they've had 6 injections and they say, I'm still progressing.
Mhm.
I feel like, how do you assess whether the therapy is actually benefiting them at that point?
Yeah, I mean it's hard. It's really hard to say, oh yeah, well, I can tell you that it's working because, the only thing we can say is that, we saw a reduction in the rate of growth compared to sham in the studies. That's really all we can say at this point. But when I'm telling them if they're discouraged by things, when I tell them, I say just essentially we we don't really have any other options here. So what we are trying to do is essentially pull the brake on a car that's going 100 miles an hour, and we're trying to, push the brake on it and see if we can get it down to maybe going 40 miles an hour or something like that, something similar to that. So it's still going to be going down the road towards, causing some more loss in vision, but at least we can keep trying to slow it down a little bit more. So far, I haven't had really, actually, interestingly enough, I haven't had a single patient who has said, well, I'm losing vision and I'm done with this. I don't want to do this anymore. They've all said, well, I do still want to keep trying to slow it down. So let's just keep going. So I haven't had anybody
Mhm.
discontinue for that reason, at least so far.
And then in terms of, monitoring for some of the adverse effects, adverse events, what's your general protocol? Are you getting, how often you're getting an OCT, how often you're doing an exam, for these patients?
So, I mean, I have some colleagues that like to bring the patients back after their first injection ever, 2 weeks later to check for any cell or anything like that. And I think that's a reasonable thing to consider, especially if you're very concerned about the IOI complications from this. But For me, I usually will just give them a pretty extensive rundown of what to look out for, a red eye, significant pain or discomfort, a lot of floaters, within a couple of weeks of the injection, any sort of thing like that, and just have them tell them that they absolutely need to call us and come in as soon as possible if that does occur. And I do not actually bring them back until it's been for their following visit, which is usually about 4 to 6 weeks later. But my main precaution is that I am looking at treating only the worst seeing eye first, and then seeing how it responds afterward about a month later before I proceed with bilateral injections if they do need it in both eyes. But some folks go as far as to do 2 weeks follow up with, looking at a full exam plus an angiogram just to make sure there's no evidence of vasculitis. I think
Mm.
for me, that's a little too much, but I think it's, whatever makes someone comfortable to proceed with continuing with therapy, I think is reasonable. I will say that any patient that does come in with inflammation on these complement inhibitors will get a wide field angiogram with me, no matter what, just to make sure there is no evidence of vasculitis in the context of the inflammation.
Sure, sure. Yeah, I can see your points of the number needed to examine for with the IVFA for someone who doesn't have symptoms is quite high,
Mhm.
given the rarity of the inflammatory events.
Mhm.
How about monitoring for CNV? Are you getting an OCT each time?
Every single time they come in, they'll get an OCT, and I actually do get OCTAs relatively regularly for these patients as well, just to make sure they're not also maybe developing or have an occult CNVM that we're not picking up on the OCT. So just in case that happens, I usually will be monitoring them even more closely.
Mhm,
But yeah,
mhm.
I do OCTs and very actually relatively frequent OCTAs on these patients as well.